This audiocast is going to review with you two areas: hormonal contraception and the risk of breast cancer, and also some challenges that you may face when, again, managing patients who have the LARC approaches to contraception. If we look at what we were going to discuss relative to breast cancer, there are three issues that I think are important. Does the use of oral contraceptives increase the risk of breast cancer? And when I say oral contraceptives, I would include the patch and the ring as well. Does the presence of a BRCA mutation change the risk among oral contraceptive users? And does the use of progestin-only contraception increase the risk of breast cancer? When you look at breast cancer, there are many factors in the early development. There are genetic factors, as noted here, a bunch of growth factors, including estrogen and progesterone, as well as tissue factors. So it is a challenge to an epidemiologist to tease out the contribution of, say, oral contraceptive use at some point in the history of the patient and determine how much of that is an important association, and of course whether, if in fact, it would be etiologic. It's also important to keep in mind that there is a time course in terms of the development of breast cancer. And from the time that a cancer first starts to the time it's detectable may be a matter of 5, 6, or even 7 years. Thus, the screening approaches that we utilize for breast cancer certainly make sense, but also it presents a challenge for an epidemiologist again, because when you study a particular group of breast cancer cases and come up with an association, say, with a particular birth control pill, it in fact may not reflect the pills that were in use, let's say 6 or 7 years ago, which may have been different formulations and different dosages. Again, another challenge for an epidemiologist. So let's review 3 of the classic studies that have associated with the understanding of breast cancer and contraception. The first, done about 20 years ago, was a large meta-analysis of 54 studies, and the evidence suggested that pill users aged less than 35 years had a slightly higher risk of being diagnosed with breast cancer, but the risk declined over time for past users. By age 50, the cumulative risk of breast cancer diagnosis was the same both in users and non-users. Further, there is no evidence that oral contraceptives, even the higher dose ones, increase the risk of breast cancer even with increasing duration of use, and there was no evidence that family history modified the risk. Now, the findings could be due to detection bias, meaning more breast exams for pill users, or it may only reflect that OCs, that is pills, promote some growth of pre-existing tumor. The second study, done about 10 years later, was a large case control study that I was fortunate myself to be one of the investigators. And in this study, women aged 35 to 64 were examined. The controls were population-based, which again probably is more reflective or perhaps more useful than using hospital-based controls. And the women with cancers were identified between 1994 and 1998 in the so-called SEER cancer registries. As you can see, most of the cases and controls had in fact used oral contraceptives, but there was no risk of breast cancer in women who had ever used any type of OC, as shown here. And among women aged 35 to 64, current or former oral contraceptive use was not associated with increased breast cancer risk. Further, there was no increase in risk with longer periods of time of use or higher doses of estrogen. Further, the initiation of the pill at a young age was not associated with an increased risk, and family history was not associated with an increased risk. The final study, done again fairly recently, involved 23 studies of 15 case control and 8 cohort with reasonable sample size, and again, similar findings. The risk of breast cancer was very low among every user. The risk was noted particularly with recent use, but decreased over time. There was no effective duration of use, and in fact, they calculated the approximate increase in lifetime risk of breast cancer was less than 1% for oral contraceptive users. What about the BRCA1 and 2 mutation groups? Again, the high-risk patients. Unfortunately, there's a paucity of studies here. In this particular meta-analysis done on 5 cases which they felt were appropriate, the overall risk among oral contraceptive users was not statistically significant. Again, an odds ratio of 1.2 is very similar to the 3 other studies we just reviewed. There also was no effective duration of use. However, the data was inadequate to analyze the effect of a positive family history. Finally, what about progestin-only contraceptives? Here again, there's a paucity of studies, And this meta-analysis completed in 2016, only 6 articles were felt reasonable enough to undergo a systematic analysis. 5 of the 6 articles reported no association between the use of any form of progestin-only contraceptives and breast cancer. However, it is clear more rigorous study is needed due to small sample sizes, variation in progestins and route of administration, and the heterogeneity of study locations. So, to answer our 3 questions, does the use of oral contraceptives increase the risk of breast cancer? Minimal, if any, increase. Does the presence of a BRCA mutation change the risk? No. And does the use of progestin-only contraception increase the risk of breast cancer? Probably no, but there is a paucity of data. Our second topic will discuss LARC management issues. And the issues that we will discuss today is what do you do to try to reduce the pain of an IUD insertion? What do you do about missing IUD strings? What about non-fundal placement of an IUD? When that's identified, what do you do? What do you do when you have a positive pregnancy test with IUD use? And what do you do when you have a non-palpable implant? When you look at painful IUD insertions, unfortunately, there is not a, shall we say, an approach that works ideally for all patients. In fact, a Cochrane review concluded that lidocaine gel placed in the cervix, non-steroidals taken beforehand, and misoprostol beforehand were not effective in reducing insertion pain in nulliparous women. The effectiveness of a paracervical block was variable. It could reduce pain in tenaculum placement and did reduce pain in a few studies. Certainly one could consider the use of misoprostol prior to a procedure or a paracervical block with difficult insertions, but again, the success rate may vary. What do you do with non-visualized strings? This is a very common occurrence. First, if you get a phone call regarding this, you do need to urge the patient to use some backup form of birth control. When you get them into the office, if you are able to sweep the strings out with a cytobrush, basically they just then undergo routine care. If you don't find it, then you need to rule out pregnancy, potentially offer emergency contraception, and then proceed with pelvic ultrasonography. If under ultrasonography the IUD is visualized in the uterus, then basically the patient needs routine care, and there's no need to do further confirmatory ultrasonographies on an ongoing basis. If you don't see it, then you need to obtain an X-ray of the abdomen and pelvis. If the IUD is not visualized, the diagnosis would be expulsion, and the patient needs to be counseled about some other form of birth control or putting in another IUD. If you do see it on X-ray, it is obviously due to a perforation at insertion, and it should be removed laparoscopically because leaving it in does lead to inflammatory responses. What do you do if you note that a IUD is non-fundal on ultrasonography, but still located in the uterus? And this doesn't really vary too much in terms of whether the patient has symptoms or is asymptomatic. The IUD stem is above the internal os. Certainly it could be left in, but the patient needs to be counseled that perhaps the efficacy could be slightly different, though unlikely, but there's no data to support that. Obviously, if the patient is having symptoms, she should certainly be presented with the option that it could be removed if she so desires. If you note that the stem is below the internal os, that is, the IUD is partially in the cervical canal, it should be removed and the patient counseled about further contraception going forward. What do you do about a positive pregnancy test with an IUD in place? First, you obtain an ultrasound. If it's an ectopic pregnancy, they can be managed medically or surgically, and you could even consider leaving the IUD in place after management of the ectopic pregnancy. If there's an intrauterine pregnancy, you need to determine if it's undesired or desired. If it's undesired, the IUD can be removed at the time of the surgical abortion or medication abortion. If it's a desired pregnancy, you do a pelvic exam and determine whether the IUD strings are visualized or not visualized. If you see here where the IUD strings are visualized, you remove the IUD with gentle traction. Leaving the IUD in place increases the risk of spontaneous miscarriage and even of mid-trimester infection, albeit that's fairly rare. When the strings aren't visualized, you look at using an ultrasound as to its location. If there's no IUD visualized, then you obtain an X-ray after the pregnancy to document that in fact it probably was expelled. Again, if it's in the cervix and can be readily removed, then certainly it should be done to reduce the risk of a miscarriage. If it's above the cervix, you do not attempt removal, but the patient needs to be counseled that she may face additional obstetrical risks such as preterm labor or even preterm rupture of the membranes or a chorioamnionitis. What about a non-palpable implant? Here again, you need to exclude pregnancy and again recommend backup contraception. You need to determine the type of implant. The older implants did not contain barium sulfate, so that they are very difficult to see and basically impossible using x-rays. However, you can also use ultrasonography with a high-frequency linear array transducer, the type of ultrasound used for IV access or for localizing a spot for a breast biopsy, and it could be used with both types in an effort to determine where it is. Certainly with the, as shown on the right, for the rod that doesn't contain barium, also you can use an MRI as well as you could with the one that does contain barium. Once you have localized it, again, you can attempt removal. Again, marking the skin over the implant may not be helpful because the implant may in fact move around as you're trying to extricate it. If it's not deeply in a muscle or near a neurovascular bundle, this oftentimes can be done in an outpatient setting with local anesthesia, with or without the high-frequency ultrasound guidance. If it's deep in the muscle or near a neurovascular bundle, certainly you should get the assistance of a surgeon who has a great deal of familiarity with the anatomy of the upper arm. And again, you will need most likely use the high-frequency linear array ultrasound guidance. So those are our review of some challenges that one faces in prescribing the so-called LARC methods.